them all over the state.
Uh-huh.
All right.
Got a few more folks filing in.
Okay. Good evening, everybody. Come on in and take a seat. We're going to get started in a few minutes. We have some housekeeping announcements before we get started. My name is Susan Polikoff-Shaw. I'm with the League of Women Voters here in Lakewood, and we want to welcome you to tonight's forum. We have a couple of
Tracy Carter, the Vice President of Government Relations from MetroHealth, Ohio. And we're going to start by letting Tracy introduce herself further and talk a little bit about an issue that's really important to her.
So good evening. So I want to say special thanks to the League of Women Voters for inviting me to participate on the panel today. Yeah, it's a high honor to speak and share what I'm passionate about with a group of women who are just as equally passionate about women health issues and opportunities. So I'm really grateful to be in this seat. I'm here because I serve as Marlene mentioned, Vice President of Government Relations for the MetroHealth system. And what that means, essentially, I'm the chief advocate for our system. It is a great joy to come to work every day and explore how to best advocate for those who have no voice or who need help speaking up. And so anything dealing with Medicaid, Medicare, scope of practice for nurses, doctors, that's on my agenda to advance. And I also really enjoy partnering with patients to tell their stories. That's most effective when you're engaging legislators on a policy issue or an opportunity. And so for me tonight, I look forward to talking about an emerging policy that's focused on prenatal care and how each of you could speak up and help get it across the finish line to final law so that more families, be it black, white, urban, rural, have better pregnancy, birth, and parenting outcomes. So look forward to tonight's conversation.
Thank you. Next to Tracy is Iris Harvey. Iris is the President and CEO of Planned Parenthood of Greater Ohio. Iris, thank you so much for being here tonight.
Thank you. I would also like to thank the League of Women Voters and Ideastream for holding this forum tonight. As Marlene said, this is a very important discussion, and I also am very pleased to be here with a great panel of experts in this area. So at Planned Parenthood, it's a brand you probably have heard of, we are, throughout Greater Ohio, we are an organization that provides safety net health care for women, for young men, and for young adults as well. And what we try and do is to make sure that anyone who needs reproductive health information, preventative care, knows that they can come to Planned Parenthood and receive that care regardless of where they live or what their income is. So reproductive health care is very important to us. And we know that you can't really think about a woman without actually thinking about her reproductive life cycle and what it means. And I'd like to share the fact that when you look at a woman, she usually, especially in the United States, and also the numbers would suggest the same in Ohio, is looking to have about 2 children in her lifetime, much smaller than in many other decades. And so that really means that she spends 3 years of her life either being pregnant or postpartum or trying to get pregnant. And the flip side of that is that during her reproductive lifetime, she's spending about 30 years or 2/3 of her life trying not to get pregnant. And so the care of her before conception, making sure that she's a healthy woman, that she has all of the economic stability that she needs, that she has housing, she's free from violence, all of that has a great deal to do with how healthy her pregnancy will be. A healthy woman is more likely to have a healthy pregnancy. If you just have a baby and then there's no health care or system to support you, then that's another opportunity for infant mortality or for maternal mortality as well. And then throughout, if she's going to have two, there's that connection in between the birth. And so, of course, there's also post the reproductive life age. And so we like to think that any society that doesn't place women at the center of its policies, especially its health policies, is missing the opportunity to really make sure you have a strong society. And I believe that you can judge a society by how well it takes care of its women and its children. And so to start out, I'll agree with Tracy that there's nothing like a story to get you going. And so I'd like to tell you the story of Evelyn and Bill. So Evelyn and Bill were two 14-year-olds, and they did what 14-year-olds sometimes do. They had unprotected sex, which we don't really want 14-year-olds to do. But what happened when they had unprotected sex at 14 years old is Evelyn got pregnant. And it was at a time when there wasn't much that she could do about that pregnancy. Her parents were embarrassed. His parents were embarrassed. And they were told you had to do one thing. You had to get married, drop out of school, and have the child. And so Evelyn and Bill got married, and they had their first child. Evelyn and Bill were my grandparents. And so hopefully you would think they left the hospital with enough information so that even though they were now only 15 years old and going into life, they would have more instruction on reproductive care so that this wouldn't happen again. But 11 months later, Evelyn was back in the hospital having a second child. Evelyn died at 16 years old on the delivery table, and she delivered a child that had cognitive problems all of his life because of the trauma of birth. And that's a problem that still exists in this country, regardless of all of the advancements that we've made on reproductive health care. Actually, of all developed countries, the United States is the deadliest place for a woman to have a child. Because if you look at our other countries, France, Germany, Japan, they have decreased maternal mortality while we've increased over the last few decades. And so we have a lot of work to do, and I will really appreciate having the conversation with you today about that.
Thank you, Iris. Wow, what a startling statistic. Wow. Well, next up is Dr. Carla Harwell. Carla is working to keep patients with us. She's with UH, and she's an internal medicine physician, and I have to tell you about Carla as her patients love her. She practices in the Huff neighborhood, and how many years have you been there, Carla? 21 years, and she has patients who are loyal and who just love her to death. And I'll let you take it from there, Carla.
Thank you. My co-panelists have already thanked the two sponsors of the program. I'd like to thank you all for taking out time in your busy schedules this evening to come and share this conversation with us. I'm sure there's other things you could be doing, but I'm appreciative of you all coming out. Again, I'm Dr. Carla Harwell, and I'm the medical director of the University Hospital's Otis Moss Jr. Health Center, which is located on the east side of Cleveland in an area known as the Fairfax community.
Oh, I said Huff, I'm sorry.
That's okay.
I'm sorry.
That's okay.
My
That's okay, yeah. So we're located in the Fairfax community. And my patient population is predominantly African American. And I have a special interest in women's health and healthcare disparities. A big buzzword today, social determinants of health, cultural competency, all of these things that affect the delivery of care to underrepresented minorities. I have a special interest in trying to empower my patients, which is about 70% women and 30% men, and trying to get patients to understand that you have to take control of your own health care, that no one's going to take better care of you than you. In the Fairfax community, the zip code determines how long you live. If you live in the Fairfax community with the zip code of 44106, your life expectancy is 67 years old. Less than 10 miles away in Lyndhurst, it's 82. Why is that? Why is that? That's my interest. And that's what I'd like to talk about this evening.
Okay, and I'm sure we're going to get to that, Carla. And rounding out our panel is another physician, Dr. Amy Hise. Dr. Hise has a couple hats, right? She's with the Case Western Reserve School of Medicine on the faculty there. And she's also an internal medicine physician at the VA hospital here in Cleveland. So you get to round things out.
Thank you very much, Marlene. Yeah, it's a great pleasure to be here and to speak on this important topic. I think I come at it from a slightly different direction. I am on faculty at the School of Medicine, and I've spent a number of years of my career doing research, sometimes basic science research, but also being involved in the research community, clinically oriented research as well. So I have an interest in inequality in terms of research, what we have historically done, and what we're trying to do as a research community to correct some of those past injustices where it comes to women's health and the inclusion of women in research. I also work in the Cleveland VA hospital. I'm an internist there on the medicine service. And, women are the fastest growing segment of our veterans population. And so oftentimes when we think of veterans, we think of, in the past, mostly men, and, they're almost 10% of our veterans population. And we have a large number of women veterans here in Cleveland. And the Cleveland VA is taking steps to improve their care for women and to modernize their care for women, and including building a new women's health center, which is going to be cutting edge on the Cleveland VA campus. So I'm very excited about that development. So I'd like to kind of touch on a couple areas as we're discussing things further, but we can expand a little bit about historically where women have been in terms of clinical research and what's been the outcome of that and how that's impacting all of our health today.
Wonderful. Can we give our panel a hand? And I know that many of you have already started sending up questions on your card, so please continue to do that. We want to hear from you. We want to hear what you're thinking tonight. And also, a couple of my colleagues are here from Ideastream. Wave your hands over there. Christy and Ann. And now we don't want to confuse you, but at the very end, they're going to hand you a card with a question on it. And it's just one simple question, easy to fill out. And we're hoping that you would fill that out for us. It's just a way for us to kind of keep track of what the folks are thinking out there who are participating in this forum. Okay, so I'm going to start one of the questions that the audience gave us because it's really good. And it's really, Amy, I'm going to direct this question at you because it's about women physicians. And the question is, how will healthcare in the U.S. change when the number of women who are physicians reaches more than 50%? Now, I know you told me that things are changing a lot in medical schools, right?
Yeah, that's true. Yeah, so actually currently women make up more than 50% of medical students in the United States. And it depends on the school. Case Western Reserve University School of Medicine has been a leader in this regard. And our classes have been more than 50% for a number of years now. Women are entering the workforce as physicians. They're facing unique challenges, however. So why do we want to support women entering the healthcare workforce, and why do we want to support women physicians? Well, there are some studies that suggest that medical care provided by a woman physician is in some ways better. There's better outcomes, there's less mortality, there's less hospital readmission rates. So women provide excellent care. There's also been studies that have shown that women spend more time talking to their patients than men physicians. I think there's some cultural issues associated with that. So I think women provide, high quality care, and for women's health, it's important to have a provider that you can talk to. But women physicians face numerous challenges, as do women in society in general. There's everything from opportunity gaps to pay gaps for women physicians. There's also harassment, and so it's been interesting to see how women physicians have addressed that. So with the Me Too movement, there's been increased interest in what's happening for women in medical school and medical training, as well as women physicians in practice.
And are things starting to come to light?
So recently,
in hospitals and in medical schools?
There was a survey by the National Academies of Science, Engineering, and Medicine in 2018, and they reported that over 50% of women medical students reported having been sexually harassed. Over 50%. And women in practice find that too. And there's barriers to our success both in academic settings as well as in hospital settings. So women in an academic institution like a school of medicine make up 50% of the assistant professors. That's sort of the lowest level of academic rank, but are predominant in the non-tenured eligible pool of those assistant professors, meaning their job security isn't the same as somebody who has tenure. And as you increase the ranks to associate professor or full professor, the number of women in each of those ranks decreases. So about 20% of full professors are women, about 20% of tenured professors are women. And when we look to our leadership in hospitals and medical schools, we don't see that women's faces are in leadership positions. I don't know how many of you walked into a hospital where you see the wall of white male directors, you know. It doesn't always feel like the most welcoming place. And Hise is taking some real initiative to try to change that. You know, we have a woman dean. She's one of 18% of deans of medical schools in this United States. And she's really working to try to increase the representation of women in leadership positions like chairs, to mentor other women physicians, and to change this culture of medicine where this kind of harassment and discrimination can exist.
Let me just play devil's advocate for a moment, because sometimes when these conversations come up about women advancing and women not being represented in certain ranks, you'll hear some people say, well, it's because women choose not to go after those positions. Or maybe because a woman is dealing with her children, she prefers to have a job where she works part-time. Is it possible that that's part of the reason that women are not represented in the upper ranks of medicine?
So, you know, it certainly is kind of low-hanging fruit to say, well, you know, women are busy with their family duties and are not really devoting time to their career, but it's really a multifactorial and complex issue. So there was a study that came out recently that showed that if you take research grants, like say to NIH, and you blind the reviewer to the gender of the applicant, that the grants are reviewed equally. But when they know the gender of the applicant, that women have less success with their grants. And so, you know, that's one aspect of this. You know, oftentimes in a panel or in a professional setting, you know, if there's a woman physician, she's called by her first name, and male physicians are called by their title. You know, that's just one way of kind of, you know, showing less respect and less professionalism to women physicians. I think women physicians have higher rates of burnout. There are opportunities that they're not getting because of overt discrimination. And I think sometimes people, you know, when they think of a physician, they think of, you know, sort of a TV doctor in a white coat, tall with gray hair. You know, there's a perception of what a physician looks like. So there's been several social media campaigns run by women physicians. I'm on the board of directors of the American Medical Women's Association, and we've partnered with people. So Time's Up Healthcare is one arm of the Time's Up movement that's really trying to deal with harassment and inequality in the healthcare workplace. There's also been a social media campaign, I Look Like a Surgeon, so you'll see the picture of the women's faces because, you know, in the operating room with the mask and the hat on, everybody kind of looks the same. And, you know, if you have surgery, you may roll in and find that everything from the anesthesiologist to the scrub nurse to your surgeon are women. So, you know, women have really penetrated all aspects of medicine, and they're not always recognized for having that role.
Well, let me get Carla in on this conversation. And again, let's try to get back to the question that was asked, which was when women, I'm assuming women have not reached 50% of physicians, right? And when they do, what will that mean for us as women? How will healthcare change? What do you think about that, Carla?
Well, like Amy said, there's been studies that have shown that women give what they consider more compassionate care, you know, that women listen more. There's been research that has shown that doctor and patient racial concordance brings about better outcomes. And that's just fancy words for saying that when you have a doctor that looks like you. So, you know, African Americans feel more comfortable with African American physicians. Women feel more comfortable with women physicians. And there are studies out there that shows that there's greater patient satisfaction, greater patient compliance and adherence to the medical regimen, and that people are happier. You know, we all we're all human. We all run in a crowd of people that have things in common with us. That's where we feel more comfortable. And that's true in the medical setting, And so I think I'm looking forward to when women take over and become the majority. It's about time, right?
I love this conversation, and I'd like to say that what would healthcare generally look like if across the spectrum, if it was woman-led, and if from the president to the top of the company, to the advocacy, to the clinicians in the health centers were delivering it, and it really was put women at the center of everything we do. I think it would look like Planned Parenthood, and I would agree with my two colleagues here that women have a different set of empathy with other women, and I think with male patients. We take more time, more attention. And I also think that we might be moving towards this moment when women do take over, because you see more, and not only more and more women going into medical school, but when you think of the way medicine has been changed in terms of it's not just the sage of the doctor in the office talking to the patient, but it's the continuum of care, the intervention, your nurse practitioner, advanced nurses, people who are making sure that there is I would say continuation and compliance with the type of care that you need. Are you taking your medicine? Are you eating well? Watching your diet, taking your high blood pressure? Those are the things that we're increasingly seeing more and more women doing. You can go around the city and you can go into a Cleveland clinic in a strip mall, right? And who's running it? A nurse practitioner. So I sort of think we're moving towards this place where women are going to start taking over of medicine, and I agree with my friends here. It's going to be terrific.
So I think we're sort of in agreement here in this room that it's going to make life better for women when we have more women physicians and more women in the medical field. But before we leave this topic, I just want to ask you, Carla, did some of what Amy was saying, did that ring true to you in terms of like your experience going through medical school, dealing with male colleagues? Did you see a lot of things that the Me Too movement will be worried about?
Well, what Amy was saying when she was describing how you can start out as an assistant professor and then you rise up to an associate professor and then a full professor. Clearly, I mean, my own experience is I'm currently an associate professor of medicine at Case Western, and I can say that Case has a lot of good programs in place to help foster and try to help elevate us up that ladder. But that may not be true at all institutions. So I can just say personally that I had a lot of support, that moved me from, the assistant rank to the associate rank, and still have, that same help and fostering to move me up to the full professorship. But, that may not be true at all institutions across the country. And like Amy said, the statistics don't lie. I mean, if you look at where we are at each of those levels, it just gets less and less and less. And if you throw in the minority factor, it's even worse, for minority, men and women.
And Tracy, I know that's not what you're here to talk about, but do you want to speak to women in MetroHealth, how women doctors are faring there? Are you seeing the numbers increasing there?
For MetroHealth, I would say what I'm encouraged by is we have a newly formed, we call it Employee Resource Group, where the C-suite, the executive leaders have come together and said, what can we do together to help every woman thrive? And that goes for the woman that's working down in the boiler room, and those who are in care delivery, and those who are actually doing the executive and administrative functions. But I was sharing with Dr. Amy today, we actually have a committee of that new group that's focused on the physician development. How can we get more women in leadership? And our physician leaders have been active in partnership with CASE, accessing those career ladder, those professional development programs. And I would say we've seen a lot of growth. There are a lot of women that want to do more. They're actually asking for more education, training, mentoring, sponsorship around the business side, because I agree with Iris to the extent you can get more women in medicine actually driving policy, driving strategy, driving operations, that's where you can make wholesale changes from a culture perspective and business perspective. So at Metro, we're just getting started. The good news is we're partnered with Hise on their development plans, and we have easily, I would say, probably a good 20% of, not 20%, but 20 active physician leaders thinking through a plan, a focused plan to help more women ascend throughout the organization. So that's good news. That's encouraging.
Well, you guys are really responding to my call for questions. I appreciate that. You're making my job much easier. So, Iris, this one is for you. And one audience member wants to get right to it, okay? They said, what will happen if Roe versus Wade is overturned?
Wow, you go for the big
I know. Whoever sent that up, they're going right for it.
I might guess who might have answered that. I will tell you the truth. If Roe v. Wade is overturned, it will be pretty bad for women. But I think that, that's a mantra that we hear every day. And that is probably not likely to happen in the next year or two. What you really need to be concerned about are the 200, 300, 400 bills that are attacking a woman and taking away a woman's right to reproductive health care, whether it's abortion, safe and legal abortion, or it's access to birth control, that happens in the state legislatures every day. And those are the things that are the tipping point that could reach the Supreme Court. And a simple decision from an Alabama or Mississippi or an Ohio could send back the decision on access to the states, all of the states, and what we know that would be terrible. So on that bigger question, if Roe v. Wade or this domino effect were to send the decisions back to the states, there are only 20 states in this country that have protected safe and legal abortion in their constitution or in some ways that the legislature could not overturn it. So that means that the rest of the states could indeed make those decisions. And we believe that at Planned Parenthood, because we do a lot of thinking about what would happen to, our 3 or 4 million patients, most of whom rely on us and other healthcare providers for basic breast cancer screenings and things of that nature. We believe that 25 million women would not have access within 3 years to the right to safe and legal abortion. And 25 million women from the time a law would send back to the states the decision-making to eliminate abortion in their state, there would be about 25 million women over a period of about 3 years who would not have that access.
That's a national number.
That's a national number. And so they would have to be moved from one state to another, find different care, find different options. So it's a reality. We see it. A 6-week ban in Ohio is before a woman knows that she's even pregnant. So for all practical purposes, it is a ban on abortion, and that has happened.
Think about that 6-week ban, or some people call it the heartbeat bill. Do you think it will make it through the courts? I know there's some other states that have already passed those.
There have been at least 18 of them. They make it through the bill. Planned Parenthood, along with the ACLU, we did indeed sue that. We won the first round, and we're waiting for the trial to begin. But many of them have been struck down. But keep trying, and sometimes it sticks.
Now, when we were speaking before, you called it an attack on women's reproductive rights, or an all-out war. Did you use the word war?
Probably. Maybe. I'm inclined. The point that I think that is really important is that if you look at the variety of legislative actions that are coming in Ohio and in other states, they actually are trying to dictate the decisions that women can make. There is an insurance bill that is trying to expand the the public rule that an insurance company or insurance organization that insures public employees can't provide abortion. But they're also now trying to say to the private sector, to any corporation, that if you're giving your employees insurance, this is not a benefit that you can control. Many of the requirements in the gag rule and in Title 10 really are defined or designed to encourage women to use what's called natural rhythm of birth control, to have abstinence-only sex education, to do things that don't empower women and take away their rights. So we're seeing a large variety. There is, and I've got my government relations friends over here. She probably has many more to talk about. But there is a bill currently in the House in Ohio that we call the Misinformation Bill. And essentially, starting in schools, primary schools, the point of this is to grade by grade by grade teach the development of a fetus. Not teach sex education, not teach human biology, but to teach that. Now, maybe there is a place for that in the context of a larger sex education, but Ohio is the only state in this nation that does not have a curriculum for health education. It's not prescribed what you have to teach. It's not prescribed who can teach it. And so that the legislature should be focusing on this little piece of health to define it, and they want to leave it to politicians. I think that's type of war.
Well, I know that, we all are concerned about, some things that happened in the past when women did not have access to abortions. But I wonder if the landscape has changed a bit because of technology, because of advances in medications that women can do abortions chemically now. I wonder, does that change the equation at all if, for example, there were more restrictions and if Roe was overturned?
I guess I would answer that by saying that what any of these legislative actions are doing is telling you and you and you and me as a woman what I should do with my body autonomy. It's saying, Iris, you don't have enough sense to make the choice. It's saying that you should let me, as a politician sitting in a state house, decide what is good for you. And so I do think that that's a problem. So to your other question, yes, we are finding, so you can have medication abortion, and that's a matter of taking, having education, taking a pill, having a dilation, and taking a second pill. But there is a bill in the House that uses no evidence base, and I have some doctors here who can probably talk, that says that if you take the first pill, and you change your mind, you can take a second pill in between the one that you're supposed to take to finish the procedure, and it will reverse it. There is no ability to reverse it. It's not evidence-based. And so our legislature is actually trying to write a bill that will experiment on women. And I think that is shameful. So yes, I think it is war on women.
So Carla, I know that you are not an OBGYN, but you do have a lot of women in your practice. What kind of effect do you think it would have on women if there were no longer access to abortions, even to contraception?
I don't think I could say anything that Iris didn't already say. I think just in a one sentence, it would just be devastating for the right to decide, what you want to do to your body. I think would just be devastating. Absolutely.
And Amy, what are your thoughts on that?
I think that Planned Parenthood does so much more than just one thing, and it's a holistic approach to an individual's health. And so, women are making reproductive choices in the context of so many other aspects of their health and their family life. It's a very complex decision-making process, and I think that women should have a trusting and two-way conversation and relationship with their healthcare provider that allows them to make that decision with their doctor. And I don't see the role that a politician plays in, that men are not having to go to a politician to ask for permission for any kind of medical treatment or procedure. There's nothing in men's health that they have to go to a politician for approval for. So it seems like, there's a disparity here that reflects some of the other bigger cultural issues we're talking about with discrimination against women and, inequalities with women. I think this is just one more example where men's health is not being regulated and women's health is.
No, we're talking with the abortion discussion, we're talking about taking something away. One thing that was added to the equation for healthcare was the expansion of Medicaid in Ohio. And we have a question about what has been the consequences of that? What are the outcomes been because we have expanded Medicaid in Ohio? I'm assuming that everybody here thinks it's a good thing, right?
I'll just say for MetroHealth, we are probably one of the largest hospital systems in the state supporting Medicaid patients. Our experience has been that Medicaid expansion worked. From a health perspective, a lot of our patients were able to have one less thing to stress about in terms of how they would pay the bill. So having that coverage mattered. We saw an increased number of patients accessing their primary care doctors, not the emergency room. We saw people complying with medication, following through on visits, and so forth. So I would say all in all, the health impact has been quite positive. And from an economic perspective, the physicians and even Iris can attest to this, if you get people in care at the right time, at the right place, following through on care and services, that should contain or lower healthcare costs. So for Ohio, I think it makes economic and health care sense.
And Carla, you talked about a person's zip code in terms of their life expectancy and the type of health care they'll receive. Did the Medicaid expansion help in that regard?
It did help in the sense that I lost a lot of patients when their insurance coverage was cut off. And so with the Medicaid expansion, patients were able to, reconnect with me as a primary care physician and not run to the emergency room because, the emergency rooms can't turn you away, whether you have insurance or not. So prior to that, patients were, inappropriately utilizing the emergency rooms as their primary care physicians because they had no other option. And so, I was just ecstatic, when that happened. And I definitely saw an influx of patients that were able to make it back to me who had previously lost that coverage.
And we talk about the social determinants of health and the impact that has on a woman's health. I would think that the Medicaid expansion was a good thing in terms of getting at some of these social determinants of health.
I would certainly say so. Medicaid expansion is directly tied to the Affordable Care Act. And so I think if you want to look at a policy that had a great impact on women and on health, I believe the Affordable Care Act has done that. And again, when we look at the difference between men and women and how decisions are made, I like to use this example that before the ACA, men could get Viagra without any copay. But women had to pay a copay for birth control pills. So post the ACA, women do not have to pay a copay for private insurance or Medicaid or anything else to have basic preventive care. They can have their cancer screening. They can have STI screening. They can have assessment for risk without worrying about having additional dollars taken out of their pocket. And so that, of course, we've heard in Washington a great deal of interest in unraveling the Affordable Care Act and many states that didn't expand it. So I believe that that would be detrimental to the health of women. And I was pleased to hear in our state of Ohio, one of the things that our governor did say is that he was not interested in pulling back on the expansion of Medicaid. And I have to give credit where credit is due.
So, yes, absolutely. So that's one of the good news stories of the night, right? But there's some things that just remain a problem for women in healthcare. Carla and Amy, women are dying from heart disease. Women are dying from cancer. How do we get at these problems with women in a holistic way?
First of all, I think we need to study women in our clinical trials and in our research. Women should have equal access as research subjects, and that's historically been an issue. So, you mentioned heart attacks. The use of a baby aspirin to prevent cardiovascular events came out of this physician health study, which was all men. There were 0 women enrolled in that study. And, women are being told to take a baby aspirin to prevent heart disease, but we don't have data to show that it works the same way in women. We know that women have different symptoms for a heart attack. They don't have the sort of classic, clutching their chest and pain radiating down their arm and, sweating and nausea. I mean, oftentimes women who are having a heart attack, it feels more like heartburn, or they feel more short of breath, or just even fatigued and tired. And so we need to raise awareness, first of all, amongst the female population that, your presenting symptoms may not look like what a guy is experiencing when he's having a heart attack. But secondly, what can we do to prevent heart attacks in women? And so we haven't really studied how medications interact with a woman's body, because most of the historic data on medications was done in studies that excluded women. In fact, the FDA in 1977 banned women of reproductive age from being included in clinical trials, and that wasn't reversed until 1993. So, there's a whole bunch of licensed medications right now that have not been studied in women. There are some studies that suggest that a woman's menstrual cycle and the hormonal changes that happen throughout the month alter their response to blood pressure medications. In this era of personalized medicine, which is a very hot topic right now, one of the things that needs to be studied is that exact thing. What if you had a blood pressure medication that, worked with your cycle and worked for where you were in that particular phase of your cycle? We don't really know the impact that hormones have on drug metabolism. We do know that women metabolize drugs differently. There's some medication that women clear from their system faster. There are other medications that women don't clear as quickly, and a classic example of that is the sleeping aid, sometimes called Ambien or Zolpidem. So it turns out that Zolpidem in women builds up to sometimes dangerous concentrations when they take the standard dose that's prescribed for men. And so, once that awareness came about that women were having more difficulty with this commonly prescribed medication, physicians got educated and were notified of this. And so we use half a dose is the standard dose for women. But there's a number of different medications like that build up in the bodies of women, and they're distributed differently. Our body composition is different than men. And a lot of medications have not yet been studied in terms of their side effects. So,
since we know this, what are the barriers right now? Is it just that people who are doing research don't want to change the way they operate? Is it that women don't know they should try to become a part of clinical trials? What are the barriers?
So there's a number of different barriers. I mean, first of all, a lot of these medications are already licensed. So to take money to go back and study them retrospectively with women populations, there just is not money available, and there's not like motivation from pharmaceutical companies to have that huge investment because clinical trials are very expensive. The federal government, though, has put in mandates. So all NIH-funded research, including clinical trials, have to include women. And it's not just the human studies. If somebody is studying a new medication in an animal model, they have to study the difference between male and female animals as part of that study. So they're starting at a very basic level, looking at those sex-related differences. I think that, there's not maybe as much of awareness of women's participation in clinical trials. And so those investigators, those principal investigators, have to take an extra effort to recruit women, to reach out to women, to include them in their trials. There's also new changes in NIH so that we don't exclude participants in clinical trial based on age, and that in the past has also been done. So as you go through your life, medications don't work the same when you're postmenopausal or when you enter, the later years of your life. And we've excluded those populations. They were considered especially vulnerable. But now, we're realizing we really need to look. If you don't have data, you don't know what to tell people. And so I think that there are still many unknowns in clinical practice when treating women. The same medications that we're using in men, we don't always know the different effect in women because we don't have that data. And that is definitely something that needs to be done.
And Carla, I talked about heart disease killing women and cancer killing women. When it comes to health disparities and minority women, African American women, are those still the two main killers of Black women and Hispanic women and others?
Well, heart disease is still the number one killer of all across the board. But African American women are 40% more likely to be obese, 60% more likely to have diabetes, 30% more likely to die of heart disease, and 55% of African American women between the ages of 50 and 84 have knee problems, are overweight, or both. This nation is in a crisis, and what that crisis is obesity, okay? And obesity is at the root of so many of these diseases. Everything I just named: heart disease, diabetes, joint pain, hypertension, cancer. I mean, you name it. Obesity is going to be part of that picture. And as a nation, we have become less physically active. It's projected by the year 2030 that almost 50% of the U.S. population will have a decline in physical activity. So what's going to happen? As we become less active, we're going to become overweight, right? As we become overweight, we're going to, it's going to lead to, so many of these other health problems.
So how do you have those conversations? It must be really hard in your practice when you have a woman who really needs to deal with that issue. How do you have that conversation?
Well, I never use, that dreaded word exercise. I use the word physical activity because you don't have to belong to a gym. You don't have to, go to a gym. You can do things just in your house. I tell women, if you're sitting around watching TV, when a commercial comes on, just get up and, march in place. Get a couple of soup cans and, and do some arm curls. It's not about having to, belong to a gym. A lot of women in the neighborhood that I practice in, it's not safe to walk around, so there's not always safe places for people to go, to be physically active. So there's things that you can do just within your home. But the biggest thing is, awareness. It's awareness, that being overweight is a health issue. I think it's a major crisis in this country. I think it's a shame. You can ride around in some neighborhoods and the billboards are about, fast food, places, and, in other neighborhoods it's not.
Is it about our
you
food
know.
supply? Is it about not having
Well,
access to fresh produce?
Yeah, those are called food deserts. Clearly in some of the neighborhoods around the city, there's food deserts. There's not a place where people can go and get healthy food. There's not healthy food choices. And, when you can get a $5 holler, which is what I call it, right? Now you can go to a $5 holler. I call it a $5 holler. When you can go to these fast food places, and for $5 you can get a burger, fries, you can get your drink. They might throw in a cookie, and if for $5, and if you want to eat the healthier option, the salad, well, that's $12, And, a lot of people that are living with these limited incomes, people that are taking care of grandkids where the parents aren't around and the children aren't really in the system, where they're getting money for them. So they're trying to make their dollars stretch, So if I can go and for $5, basically probably feed 2 kids off of one meal, that's what I'm going to buy. so it's not healthy, food choices. Everything is supersized. I mean, I get sucked in it myself, when I drive up to McDonald's. I mean, I love their fish sandwich, okay? I'll put it out there. And when one fish sandwich costs $3.59, or I could get 2 for $5, I really don't want to, but it's a better deal, I'll eat the other one later, and I can't, and I eat them both that same night, so, it's, and for 29 or 39 more cents, you can, supersize the fries, so, our portion, okay, all right.
Just don't let your patients see you.
Yeah, all right, don't
See
show
you
them
in the
this,
line.
yeah. So,
But-
yeah, it's tough, and, people that are dealing with these limited incomes, I had a teaching exercise once. I teach the internal medicine residents at university hospitals, and I did a exercise with them where I gave them $20 and told them to catch the public transportation bus down to one of the local, food, supermarkets, and for $20, and you have a family of 3 to feed, come back with some healthy food choices.
I bet that was educational.
It was educational, yeah, because they didn't do too well. They didn't do too well with that. But I said, so these are some of the problems that the patients that you're taking care of face on a daily basis. How do I make my last $20 stretch? And when you can buy a 5-pound bag of potatoes and a loaf of bread and that dollar fruit juice stuff that you can drink that's probably just sugar water, and buy a pound of, bologna, that's going to feed. That's going to feed the family, Is that the healthiest choice? Absolutely not.
Well, on the one hand, we've talked about how, Medicaid expansion has increased access for women, and women could have now more access to preventative care, right? But then on the other hand, we know a lot of health care is not what happens when you're in the hospital or when you're in the doctor's office. It's the things you're talking about, right, Carla? So I wonder if this obesity epidemic you're talking about, does it play into some of the other issues that particularly Black women are dealing with in terms of maternal mortality, infant mortality? Do we know if obesity has a role in that that's affecting Black women at such higher rates?
Well, I would have to venture to say absolutely. I mean, I'm not a researcher in that area. I don't know if Amy can speak any more to that. But again, I think obesity is at the core of, like I said, almost everything in any disease state, that you throw out. I mean, even when a woman is pregnant, we're told to only gain, so much weight, and, babies are born, prematurely because the mom has, gained so much weight, which then raises her blood pressure. Now the blood pressure is up. Now the baby's in danger.
Right.
So, it's you have your pregnancy-induced hypertension. You have eclampsia, where the babies have to now be, by C-section, or whatever, taken out sooner because the mom's in danger. So it's, when I say it's an epidemic, it is really, I think, just at the forefront of so many disease states that are affecting our women. And, women, we're supposed to be superwoman, right? We take care of everyone sometimes but ourselves. Yep. We're the last ones, sometimes we're the last ones to eat, so I know a lot of my patients will make sure that the family is fed well first, and then, she'll go and just snack on some potato chips and drink a soda, so.
Well, I know that, Tracy, you want to get the legislature involved in trying to get more preventative care to women. Tell us about that effort.
So for those of you in the room who may not know, Cleveland is in a crisis state relative to infant mortality. And we talked about the statistics on the radio earlier today. But the infant mortality rate, and that's defined as the number of infant deaths per 1,000 live births, nationally the rate is at 5.8. Ohio's at 7.2. Cuyahoga County's at 10.2. But when you look in the city of Cleveland, we're at 15.1 for African American families. It's off the charts.
It's off the chart like double or 3 times.
Right. So there's about 14,000 plus births in our county. on an annual basis. The last data shared indicated that 118 babies didn't make it, and 67% of the 118 babies were Black. So there is a crisis, and when we drilled down on the numbers of what were the contributing factors, 82 of those babies, of the 82 of the 118 were prematurity related, 13 sleep related, 12 birth defects, and then 11 with medical causes undetermined or accidents. So the red alert, we got a problem. So within our city, within our county, there is a group called First Year Cleveland. It's going on about 5 years old. Over 200 plus advocates, leaders, organizations, grassroots, everyone is hands on deck trying to figure out how to eliminate infant mortality and reduce the racial disparity with the outcomes. And so this body has partnered with Representative Stephanie House, representing Cleveland, and Representative Manning out of North Ridgeville to say, what can we do through law? And Iris's point about if you want to impact women's health, make sure you keep an eye out on what's happening with federal and state law, because a lot is happening with the power of pen that can change our lives overnight. So that law, the policy matters. So for us, we're partnering with these two representatives, Democrat and Republican, to advance a bill. It's HB 11. And it's designed to improve or strengthen prenatal care throughout the state. So as I shared earlier today, this is largely to help African American women, but also all other populations as well, be it urban or rural environments. And the bill calls for enhanced coverage for dental cleaning, at least twice a year for women, prenatal and postnatal. The oral health impacts the body, so the state legislators want to pay for that service. Increase smoking cessation programs, because anyone in the home that smokes impacts that mom and the baby. So they want to make smoking cessation available to anyone that's in the home. I think that's a major step forward. Increase lead safety education and information, so that if you are in an environment that is not safe from an environmental perspective, we need to figure out how to get you in a healthier environment. And then
we all know Cleveland has a huge issue
Absolutely.
with lead and housing.
Right. And then also investing more in group prenatal care. It's evidence-based practice. You get more moms in a group environment, like a support group. They're learning about diet. They're learning about exercise, or the P word, physical activity. They're learning about smoking cessation. They're learning about healthier relationships, self-esteem, all those things that they need to get their mind, body, and spirit in a healthier state so they can deliver a healthier child. So HB 11 is something that we're encouraged by. It's a lot of work, but it's work worth doing. So
Where does that stand?
So the House voted it out of the committee in June, 93-0, which is like unbelievable that you had that type of voting outcome. And now last week it was taken up by the Senate Health and Human Services and Medicaid Committee. So Representative, or I should say Senator Antonio from this region, she's in key leadership with this committee that will be taking a look at the bill. And so I invite all of you to just make sure you stay in touch with her. Senator Burke and Senator Hoffman are in leadership to actually review this bill, shape it, and get it moving on a path to become law so we can have better pregnancy and birth outcomes for all women in Ohio.
Well, we all know in the state of Ohio, Republicans are basically in control of the state legislature. So are Republicans behind this effort?
Yes, the bill co-sponsors Representative Manning out of North Ridgeville. And again, with a 93-0 vote on the House side, they were engaged. So they recognize the statistics, the outcomes. And again, the birth outcomes I mentioned, or the death outcomes I mentioned for this state, they're not only alarming for Cuyahoga County, but Summit, Franklin, your larger communities.
Larger metropolitan areas.
Yes, high risk, but then also you look at some rural communities and they have some concerns as well. So I think, again, when we look at this opportunity, this is one bill, HB 11, that everyone could get behind and move into law.
Okay, well, definitely keep our eye on that one.
Thank you.
Now, I think we better get to some of these audience questions before we run out of time. This is one that's really interesting. An audience member wants to know, could a public or single payer health system be more effective in delivering proper care, especially to women in need, compared to private healthcare system? If so, what are the potential consequences? I know this is a big question. I know it's a big question. It's being debated by our presidential candidates right now. But it would be interesting to hear you all weigh in on this. I'll start at the far end, Amy. Do you have any thoughts on it?
I have some experience with a model of a universal payer system, which is the VA, the VHA, the Veterans Health Administration. It covers community clinics as well as hospital systems. It incorporates home care services. We have home-based primary care where people come in the home. It's a whole continuum of care, and it's all unified by a single payer, single policies, single medical record system. So if I have a veteran who's visiting Cleveland and they're from, San Jose, California, I can, find out what that green pill is that they ran out of because I can look at their current prescriptions. And so there's continuity of care because of that communication system. I think that's also, it allows for customization. So our veterans have very specific healthcare related issues from their service. And so we are able to address that and provide them services in a very comprehensive way.
That's a single payer system.
That's a single payer system. And I think that the veterans love having that available to them. They don't have to come to the VA hospital and say, well, I'm wondering if my insurance is going to cover, this CAT scan that you want to order so that you can see if I have appendicitis. We're able to do that. And then we also are able to integrate our pre-hospital care through our primary care clinics and our post-hospital care. We can provide very close follow-up for at-risk patients when they're first discharged from the hospital. And we can put in place policies to prevent people from having to come to the hospital because we're able to manage their medical conditions with a team approach. And I think a lot of private health insurance doesn't have that level of communication, that level of integration. So from my experience as a provider within the VA medical system, that's a real advantage.
I will say, though, it wasn't too long ago, a couple years ago, even though we heard a lot of stories about vets saying, well, I can't get in. I'm having to wait this amount of time for this service. And I think that's the big fear with the single payer system.
I think if you take a big healthcare system and you try to cut costs, the politicians are trying to cut costs and they don't fund the system, that's where we got into some of these shortages. So if you underfund a system, it's not going to work. If you're not paying to have those comprehensive services available to patients, and you're saying, well, I want to really save money, or in the case of some private insurance companies, where do you think all that cost saving is going? It's not going back into the patient's pockets. So, the motivation to try to cut costs, save money, patients are paying the price now. And it's not just in the VA. I think people who have private health insurance also realize that their health insurance doesn't cover what it used to, and their copays for prescriptions are higher, and the cost of prescriptions are different. If you bought insulin 25 years ago, you didn't have to make a decision between paying your rent and paying for your insulin. There's the healthcare system that we have in this country has been run amok, and it's, a lot of it has to do with putting that kind of for-profit business model on top of something that shouldn't really be. Profit should not be driving our healthcare decisions. They should be evidence-based, and they should be what works for our patients and our communities.
Now, Carla, I don't know if you can weigh in on this or not because you work for UH. I'm not sure where the hospital systems land on the idea of a single payer system, because you often hear them say that what the government reimburses them now for Medicaid and Medicare patients is not enough to cover operating costs.
A lot of this is above my pay grade, right? My personal opinion, is obviously there's some pros and cons, to either model of care. But I'd like to bring up something called bundle payment models. Is anyone in the room aware of bundled payment models? So that's something that's down the pike where, so an example now is, let's say you break your arm You go to the ER, they take an x-ray, they say, oh, you need a cast, and they set your arm in the cast, but somehow something kind of didn't go quite right, and they have to go back and take the cast off, and now you need surgery, so then you go to surgery. So as it stands now, a physician will get paid for all of that, all of that. This new bundled payment model is now going to be, well, we're going to pay you, $10,000 for a broken arm. And that's it. Now, whatever you do within the context of that $10,000, that's all you get.
So whatever treatment you get.
Whatever
Or,
treatment,
tests
if
you
you have to
give
go
and-
back and redo something, if you need physical therapy, if
Patient comes back 10 times.
whatever, that's all you're going to get, okay? So, there's a move to do that now.
From the federal
From
government.
the federal
CMS.
government to cut down on this ever-rising, cost. So, I don't know that there's an answer. I think, obviously there's pros and cons to this whole thing. I mean, I think there's, for the United States to be where we are, we have some of the poorest healthcare in the world.
We spend a lot of money.
And we spend a lot of money on it.
It's interesting, though, Iris, I wonder what your thoughts are on this, because you're on the receiving end of the federal government taking some money away. So if the federal government is paying for everything, politics can't get in the way of the government funding certain things, right?
It does get in the way. I guess I have a number of thoughts. One is the question is to the single payer. The question is, do we as a country have the will? I agree with all of your comments. And what we did to the Affordable Care Act is an example of we don't have the will to really lean into it. And so I think that is quite disappointing. And we hear on the stage with all the presidential hopefuls a variety of ways of going at this, and I'm not sure that it's going to be as easy as anyone says. I would also like to say that there's some other things I think that are important for us to think about, especially with the care of women, and that is that 44% of people in this country are covered by private insurance from their employer. And there's a major opportunity for employers to lean in on health care for women. So how many of you have a wellness program at your employer? Okay, and they, right, they encourage you, as Carla says, to be less obese. They encourage you to check your diabetes and do a variety of things. Few of them are leaning in on women's issues. First of all, how many, I think only about 60% of companies actually give women paid maternity leave. We're still fighting for pay equity. And so I think another opportunity for corporate employers is to think about how do you take more time to care for women. About $1 in $5 of insurance costs go to pregnancy and related areas. And so, but we also know that half of pregnancies in this country are unplanned and unintended. So that puts a strain on a woman in terms of managing her time at the office, the time off, lowering her productivity. It also can have an impact, whether or not it should, on her advancement within the organization. And so I think there's an opportunity for great employers to think about how they can build health systems within their insurance plan that are more user-friendly to women. And not only women, to family. What do women need? They need child care. I don't have any children, but I hear all of my friends say, oh my gosh, a week's worth of child care is half of what they're making. Mm-hmm. So I think there is.
So working within the system we have.
Yes,
not
absolutely.
necessarily starting a whole
Yes.
new system. Tracy, did you want to weigh in on this topic?
So I have a couple of thoughts. The single payer model, just because GR is what I do, government relations. I work a lot with Republicans. As long as they're dominating the seat of power, that will never fly politically. So what our position is to advocate for all people to be insured, be it publicly insured or private. We find that to be a more reasonable approach given the political environment. MetroHealth is easily 73% publicly insured. And so when we talk about having a stake in and interest in what the federal government or state and even local government is doing, that is a high priority for us. So our position is to be proactive with them and want to be positioned as an expert in healthcare. So if you want to figure out how to better deliver care to people where they are, do it creatively in a quality fashion at a lower cost, we want to be at the seat. We don't, someone once told me from an advocacy perspective, the goal is always to set the table and not be on the menu. So we try to say, let us help you set the table so that whatever is that has to move forward is going to be in the best interest of the patient. So that's what I'll say about the government and healthcare. Iris's point about employers taking a look at what they're doing to better support women, I think is spot on in terms of having a real shot at having more women be protected and safer and heard. My employer, MetroHealth, we did an analysis within the last 2 years, and found that there was a pocket of women that work for us who weren't even earning at least $15 an hour. So our leadership, our board, made a decision to make sure everyone, particularly this group of individuals, earned at least $15 an hour. We're taking a look at flex time, looking at daycare. We're looking at breastfeeding. What accommodations do we have for women across our campus and service site to support that? So the good news is a lot of these policy solutions or considerations are being driven by that employee resource group I mentioned earlier, our Women at Metro. And again, it's at the highest level of leadership that they're saying, we are at the table. Our CEO is encouraging us to think about what he can put in place to make sure every woman thrives. And so these are just some of the things we're starting to think through and implement. So it's pretty exciting stuff.
One person sent in a lot of really great, thoughtful questions, but in the interest of time, I'll just pick one. They wanted to know, what is the one thing you think we could do? And they're talking about healthcare providers, people who work in the medical setting. What is the one thing you think we could do to help reduce infant mortality in our communities?
Is a complex issue. There's not one easy solution. You know, a lot of researchers have been looking at this. In fact, one of my colleagues was one of the people who studied the role of dental health and oral hygiene in preterm birth. You know, I think it's a complex issue, and so it should be addressed probably by providing more access to prenatal care, early prenatal care, consistent prenatal care, so that the medical provider and the pregnant patient together can work to address these multiple factors that impact on infant mortality. So, you know, that's the key. You know, women who don't get good prenatal care and good access to early prenatal care.
Okay, I'm going to move on to the next question. This might be a good one for Tracy. What's the best way for us to stay up to date on legislation regarding women's health?
Iris, I want you to jump in because I say there's a HANA report that is pretty up to date on emerging policy considerations, and the HANA report, HANNAH, HANA report. And I would say at the national level, I take a look at the Kaiser Family Foundation. That's my to go to, pretty neutral. And I would say, too, always work to build a relationship with your local officials at all levels of government. Because like Iris has mentioned, on any given day, there's something moving that can impact your life and your family's life. So to the extent you're staying in touch with them and asking the question how you could be of helpful to any policy solution to improve the health and economic well-being of women, I think is where your time will be best spent.
So, Iris, I think think you might be best to handle this question. Is the data shows teenage pregnancy appears to be declining. If that's true, why is it happening?
Oh, that is a great question. Yes, teenage pregnancy is at an all-time low. It is declining. I will still say that 80% of teen pregnancies are unplanned and unattended, and a teen that has a pregnancy is much less likely to finish school and to get a degree and to go on to college. The truth is that to a large extent, you have both access to birth control and sex education in a greater degree than we've had before. I think those are two of the major things, and all of the research that I've read says indeed that is. If you are, and I think teens are having are abstaining a little bit longer than before. But we know if you give people the information that they need to make good choices, and you also help them understand the consequences, that they then do make good choices, and having that access, that seems to have done.
As a parent of a 16-year-old boy, that is like music to my ears. Okay. So women live longer than men. How is the healthcare system adapting to longer female lifespans? I mean, I think, has it always been true? The women outlived men? Yeah. So we're living even longer, though, I guess now. Do we see the healthcare system adapting at all? Anybody want to take that one?
I think that as a society, we are not adapting to our longer lifespans. I mean, as people get older, there's limited choices in terms of housing that adapts to that. Assisted living and long-term care are very expensive options. Most people can't afford long-term care insurance, and the insurance often doesn't cover all the costs associated with that. As a society, we're relying on Medicaid to provide long-term care to our oldest residents, and that's not what Medicaid was intended for. So I think the fact that we are living longer, often healthier, but sometimes living with, chronic medical conditions, we don't have a system in place to handle that. And we really need to think as a whole community about how we're going to best address that.
So I know we could say a lot about that. That's a big discussion, but we've only got a few minutes, so I'm just going to keep it moving so we can get to more questions. This is a long question, and I won't read the whole question, but a person talked about an experience that they had in the hospital where basically the male doctor, did not take them serious, and a nurse whispered into this person's ear, go see a GYN. So we've talked a lot today about, female physicians and the need for more female physicians, but we still have a lot of men physicians. So this person wants to know, how can we get male physicians to, take these things seriously and take women's issues more seriously?
Well, I think one thing we have to remember is that we all bring to the table something called unconscious bias. And that carries over into the medical profession, unfortunately. And so, I think what I do with my patients, again, part of this empowerment is you have to be happy and you have to be comfortable with your healthcare provider. I'll say all the time, doctors come a dime a dozen. If you get bad service from a restaurant, you don't go back to that restaurant. You don't keep, patronizing a place that, you got bad service. Now, this individual that was, in the hospital, that might be a little different, in that setting. But once you get out of that inpatient setting and you're now in that outpatient setting, you have to make sure that you feel comfortable with your physician, because the doctor-patient relationship, to me, it's like a marriage, and unfortunately, not all marriages last. I've had separations, and they've come back, and I've had divorces and they haven't come back, So I mean, it has to be, a good fit, and it should be a 50-50 relationship. Gone are the days of that Marcus Welby, sort of paternalistic, type of medicine where whatever the physician says, that's what goes. So, patients are coming in, you guys are, women, we're empowering ourselves and we're coming in, we've Googled things and, we've looked things up. I mean, sometimes we come in with the, right information, but in the wrong setting. I had an 18-year-old who swore to me that she saw on Dr. Oz that she's supposed to have a colonoscopy. And honestly, and I said, I really think you either were texting or went to the bathroom or you did something where you missed starting at age 50, but she literally made an appointment with me just for that reason. Yeah. But I commended her though, because, she was trying to be she's trying to take control of her health care, and I think we kind of mentioned earlier, that, women, sometimes feel more comfortable with, a woman doctor. I laughed when you were reading it and you said the nurse whispered in her ear, go see a GYN. I said, well, God forbid she get a male GYN, when she goes there, maybe ask for a woman, But, I think that, women, we've been in the trenches for way too long, and we've gone through women movements and, we've gone through all of this. And, I'm just pleased, when I see women, standing up for themselves in all arenas, not just healthcare, in the workplace and just in relationships. And, it's about time. It's about time.
I think those are great words to end on, don't you? Can we thank our panel? Dr. Amy Hise, Dr. Carla Harwell, Iris Harvey, and Tracy Carter. Thank you all so much for being here. Thank you to the audience for those wonderful questions. I'm sorry I didn't get to all of them. And please, please fill out that form from Ideastream. And Christy, the beautiful blonde over here, will be happy to take those from you. Thank you all for coming.